Hi everyone, thank you for joining another Thursday 15 session. So this session is on acute paediatrics with Young Chan, who is a doctor. He'll be leading you guys through the session. I'll be around to answer questions though. So if there's anything you're not sure about, just pop it in the chat. And if Young's busy presenting or busy talking, I can fire some answers off as well. If you've been here before, you know how it works. We'll do 15 multiple choice questions to start off with, and you'll get a minute for each question. And then we'll go through the questions, the answers, and do a bit of teaching as well. So I'll hand it over.
Okay, hi everyone. As you've heard, I'm Young. I'm one of the F1s based at East Lancashire. So as I understand, like Alex said, this is just a quick sort of exam style multiple choice questions. We'll go through them. I'll try and not talk too much at the end. I know we're quite pressed for time, but you should, about the difficulty of the questions is all stuff that you should know if you've revised paediatrics by the end of.
Hi Young, can you hear us? We can't hear you.
Oh,
if there's anything you're saying.
Hello? Hello? Hello?
Oh, you can hear. Oh, it's just me. Sorry.
Okay.
Very sorry.
Fine. Okay. Where was I? But yeah, the difficulty level of the questions is meant to be for anyone who's revised paediatrics enough for finals or for your, end of block exam or whatever it is you've got. It's just a pointer to the level of knowledge you should have. It doesn't cover all of paediatrics, of course. But yeah, we'll go through them and then we'll talk more later on. So we're looking at acute scenarios. So the first question. So a 3-year-old boy presents to see you with 2 days dry cough and fever with past medical history of asthma. On examination, you notice a harsh audible stridor and an intercostal recession. Auscultation finds that no further added sounds. Rest rate is 40, status is 97 on air, heart rate is 135, temperature is 38. You decide to admit him for treatment and monitoring. Given the most likely diagnosis, what's the most appropriate initial treatment? So you'll have roughly 45 seconds to a minute per question, and then we'll move on, and then we'll go through them at the end. Okay, moving on. Question 2. 8-year-old girl presents to A&E in a wheelchair. She is complaining of severe pain in her left hip that came on hours ago. On examination, the affected hip joint appears red, hot, and mildly swollen. There's no active flexion of the hip due to pain, and passive flexion is limited to 10 degrees. Which of the following investigations is most important in guiding management and should be prioritized in this scenario? Again, 45 seconds or so.
Okay, moving on. So question 3, you are working on a neonatal unit. A 3-day-old neonate becomes visibly jaundiced with mild signs of respiratory distress. The baby is otherwise stable. You learn that the mother, gravida 1+1, had a previous termination of pregnancy with the same partner, and she missed multiple antenatal visits for this pregnancy. Which of the following is most useful in ruling out causes in this scenario? Okay, moving on. A 14-year-old boy presented to CAU or Child Assessment Unit with 3 days of unilateral scrotal pain and swelling. He denies any dysuria or urethral discharge. On examination, the right testis is grossly swollen, but no distinct mass is palpated. Swelling does not transilluminate and is mildly tender to touch. Cremasteric reflex is present. On further questioning, you learn that he did not receive the MMR vaccine, and 1 week prior to admission, he developed a painful swelling in his jaw with fever, which his parents did not seek medical attention for. Which of the following is least useful in ruling out testicular torsion? Number 5, a 5-year-old girl presents to GP with 3 days of low-grade fever and an erythematous generalized rash. She also had a sore throat 5 days ago and is now resolving. On examination of the face, you find the signs as shown in the picture on the slide. And which of the following is the least appropriate given the most likely diagnosis? Next question. Which of the following congenital heart defects cannot be treated by giving prostaglandin? Okay, next question. 15-year-old girl presented to ED with non-specific abdominal pain and nausea and vomiting. On further questioning, she has been passing increased volume of urine about 10 times today, and she says she's been feeling thirsty all day. She has no significant past medical history. On examination, she is clinically dehydrated, moderately tachycardic, and tachypneic. An arrest happened next door, and you went to help. When you returned, she is now less responsive and hypotensive. Given the most likely diagnosis, which of the following is not part of the standard management regime? Okay, I think a few people have said they want to read the questions themselves, so I'll just be quiet for a few minutes, for a minute exactly. I think someone asked what's FRII in the previous question. It's fixed rate insulin infusion. Moving on to question 10 for people who didn't. Question 11. Oops, sorry about that. Question 12. And then question 13. Okay, a few more seconds on 13. Okay, question 14. And finally, question 15. Okay, so that's the end of the questions. Are there any questions people would like to go back to, especially the first few, maybe? just pop it in the chat. I'll roll it back to that question, and then we can, so we got a couple of minutes for the half-hour mark before we do the polls and things. Question 9. There's question 9 again. Okay, question 1 next. Any other requests? Give a couple more seconds for question 9 and then 1 and 2. Okay. Okay, moving back to 1. And then got question 2 back as well. Okay, hopefully that's plenty of time. So before we go into the polls, I'm just going to pause for sharing, if that's okay. Okay, can somebody tell me if they can see just a starting slide and no notes or anything?
We can still see question 2.
Okay. Right, hold on. What about now? Is it back to the first slide, back to the original introductory slide?
Yeah, it's back on the introduction slide now.
And it's just a slide, no like notes or anything.
No, can't see any notes.
Excellent, that's what I needed. Okay. So let's go to the poll session. Let's just run through these. Okay. So now I can, if I just pop the polls up. Yeah. So obviously ignore the E option. There wasn't an E option, but if you put in the polls which option you went for. Okay. Just waiting for a few more. I think over half it's a good place to start. For me to start chatting. But so far, we've got the 5 went for A, 5 went for C. Interesting. Any more for any more? Okay, right. So as you can see, the answer is C. corticosteroids. I think I released that a little bit too early, my bad. But the diagnosis here is croup. And you can tell it's croup. The main pointer in history is the audible stridor, which means it's an upper airway problem. So instantly you're thinking either croup or epiglottitis. And given that the overall clinical picture, there's no sort of overt airway problems as such. You think more croup than epiglottitis essentially. And if you're suspecting croup, then all children with suspected croup should receive oral dexamethasone, to be precise. Adrenaline nebs can be used, but it's not the first line, so it's not initial treatment. And then oxygen, it's not really, the SATs is not that low, so oxygen is not prioritized. And salbutamol nebs is obviously more for airway obstruction in, say, asthma attacks. So the correct answer here is oral steroids. Any questions about question 1 before we move on to the next? No. Okay. So question 2, let's relaunch it. Okay, let's see what people put for question 2. Okay. Yeah, most of you went for A, which is a synovial fluid aspiration. For this, a single joint that's red hot and swollen in a child, especially, you need to exclude septic arthritis, and therefore you want to aspirate the joint and you want to send it for cultures. And this, in this case, in this scenario, it does fit with, it's acute onset, a very acute onset. It's a single joint, and there was no other, there's no other pointer in the history to say it's a juvenile arthritis or anything else. So in this case, the most important thing to do is to investigate for septic arthritis and treat it as that as well. So you would, in this case, probably start it before you get the culture results. The most common organism is S. aureus. So if you were to start antibiotics empirically, which you normally would, you would use flucloxacillin. And then obviously you can change after, based on the sensitivity result. But for most children, it's not the most common cause of painful hip or a limb in children, but this is the most dangerous, you should say. So it's always there's obviously other differentials you need to think about, which we don't have time to go in details about. Okay. Any questions about question 2? So why wouldn't you do blood culture? Okay. So in this instance, you can do blood cultures later on, but because it's clearly a localized infection, and the infection is likely to be in the joint based on the presentation. So you always want to do, you'd always try to do to culture the source of the infection if you can. So say if you had a chest infection, you would want to do a sputum culture, and if you had a joint infection, you'd want to aspirate the joint and then send for culture. But yes, and you're right. Later on, if it's looking more and more likely to be infection, or worse still, if they're showing systemic signs of infection, i.e. sepsis, then you would probably do both at the same time. But in this scenario, you do joint fluid culture first. Hope that answers your question. Yes, so local for children, you probably would, but every patient is different. Some people can deal without. It's not an absolute must to use local, I don't think. But I suppose it's just nicer, isn't it? I suppose, but sometimes people say doing the local injections themselves is quite painful, so depend on the patient really, like Pam said. Okay. All right, moving on. Question 3. So that was the neonate question, the jaundice question. So let's see what people put for this one. Just waiting for a few more responses. Okay, so most of you went for A, and direct Coombs test, and that is correct. Now, neonatal jaundice is in itself a massive topic because there's a whole host of reasons why there can be jaundice. The most harmless of all, of course, is physiological jaundice, which goes away within, say, 24 to 48 hours after birth. Sometimes infections can do it. Thyroid problems can cause it. But most importantly, the most studied or most talked about reason is hemolytic anemia, for, again, a whole host of reasons, which is why it's a big topic in itself. And in this scenario, so we've got jaundice baby, and we've got a mother who had a previous termination of pregnancy and missed multiple antenatal visits for this pregnancy. So those are the pointers that is pointing towards a hemolysis because of rhesus disease, which is, again, the most studied cause of neonatal jaundice. I was just checking the chat, sorry. So someone asked what G2P 1+1 was. So I think Alex has explained already. So gravidum is how many pregnancies you've had. So whether they're delivered or not by the end, it doesn't matter. So even if it's a miscarriage or termination, each successful pregnancy is a G1. So you can add one on, including current pregnancies. And then P is how many deliveries you've had. So if you successfully delivered the baby before, then it's P1. But in this case, it's 1+1 because, and the +1 part would either be miscarriages, stillbirth, or termination, things like that. Whereas a full P1 would be, or P2 would be 1 or 2 fully successful deliveries. So that's what that meant in obstetrics kind of notation, if you like. So yes, so in this case, you want to exclude hemolysis because it's likely that the mom didn't go for antenatal visit for the screening, and we want to know because it's important in sort of med school in the curriculum because it's something that we can prevent by giving anti-D in the antenatal period, and there are many sensitizing events, and which termination of pregnancy in itself is a sensitizing event. But yeah, so that's kind of just the question. Like I said, the other options in this questions are all relevant. You would do that still. So, bilirubin, of course, because you want to see how much bilirubin there is in the baby that's built up. FVC, you want to see the reticulocyte, you want to assess the anemia because the baby is showing signs of anemia. And blood film is very useful. In fact, you can, by looking at the morphology of the red blood cells, you can tell different causes of anemias apart. But in the first instance, you want to know if it's in this scenario, you want to know if it's rhesus disease or not. So to find that out, you want to do a direct Acute test, which looks for antibodies on the surface of the red blood cells, essentially. Is that okay? Any questions about this question 3? No. Okay. Question 4. So, I need to read a long chat.
And just quickly, there's a couple of people who said they need to leave a little bit early. I've put the feedback link in the chat. Answer the feedback in order to get the slides and the recording sent through, because it takes your email there. So make sure you fill that in before you go.
Okay, right. So for those who are staying with us, so there's got the poll up for question 4. Interesting. So okay, we'll wait for a few more responses. Okay, most of you went for D, urine culture. Very good. So yes, that is the correct answer, urine cultures. For interest, do you know, can anybody name the most likely diagnosis in this case? Put it in the chat if you think you know what the diagnosis is. Or, well, yeah, most likely diagnosis. Anyone? No? So I was trying to make it a case of orchitis secondary to mumps. Now, there's a few giveaways in the question. The way that this, so it's unilateral, obviously, and that doesn't really help, but there's no dysuria or urethral discharge, so that's less likely to be things like epididymis or UTI-related things. Chromosteric reflex is present, so it's less likely to be testicular torsion. And the biggest pointer is that he didn't have the MMR vaccine, and so he's more likely to get mumps. And then prior to the admission, he had painful swelling in his jaw. So I'm trying to describe the parotitis that you get with mumps. And a common complication of mumps is that you can get orchitis, either unilaterally or bilaterally. So that's a diagnosis. Now, in this case, urine culture, like I said, is the least useful because the history doesn't really point to STI or a UTI kind of picture, so urine culture wouldn't add much in pointing towards diagnosis. In this case, the most useful is probably going to be ultrasound, personally. So ultrasound of the testis is often the investigation of choice when you're investigating scrotal lesions, if you like. Unless, of course, you are suspecting torsion. Let's say it's very bad pain, the reflex the cremasteric reflex is absent, and things like that. Yeah, I suppose the boy in this case is in the right sort of age range as well. But in which case, if you are suspecting torsion, then if in doubt, you'll take it to theatre and you'll explore and maybe treat at the same time. And for interest, Pren's test, the first option A, is a positive Pren's test is when you elevate the testes and the pain is relieved. And if that's present, then that suggests epididymal orchitis. Again, which, you know, can be useful. You know, it's more useful than a urine culture, because if that is positive, then maybe you're thinking more towards orchitis rather than torsion, that kind of thing. If that makes sense. Any questions about this question? No? Okay, moving on. So let's get, I think I need to get the poll back up. Okay, so this classic peds with a child with fever and rash and things seems to be what they get most of the time. Okay. Okay. So most of you went for B, sent home with safety netting, and that is correct. So the diagnosis here is scarlet fever. Okay, the classic case of scarlet fever where you have a sort of generalized rash. There's pretty much just red, essentially. There's not much you can say about it. But you get perioral staring, as you can see in the picture, where there's rashes everywhere but around the mouth. Okay. And then you get strawberry tongue, again, it's shown on the picture. And then before you get the rash and the fever and things like that, you get a lot of the times you get sore throat, which is likely a case of strep throat, i.e. pharyngitis caused by strep pyogenes. Okay. So diagnosis scarlet fever, and in this case, the diagnosis, then to confirm the diagnosis, you do a throat swab, and then you can do a anti-streptomycin O titer, is what it's called. This the test that you use to confirm the presence of the bacteria. And then you would, in this case, you would start antibiotics. The recommended one is Pen-V, essentially, for 5 to 10 days orally to start with. And you do need to isolate. For children who have scarlet fever, the advice is that you should isolate about 24 hours after you start antibiotics. So in this case, which by elimination, you shouldn't just send them home, which is very sensible of you guys. Is this parvovirus 19? So the parvovirus 19, the rash with that one is slap cheek, and you wouldn't get strawberry tongue, and you usually wouldn't get. It's not typical to get a sore throat before that either. So with those things, it's scarlet fever. That's the diagnosis. Yes, you would give antibiotics. You would. You'd give penicillin, essentially. Phenoxymethylpenicillin, to be precise. You'd give it for 5 days orally. Okay. which is why sending home is not correct. Sending home is doing and reassuring is not enough. So the question was asking for least appropriate, wasn't it? So is that all right? Does that make sense? Okay. Everything I say, by the way, I should probably have said this earlier, but in the slides that hopefully will be shared out later, there's diagnosis, if it's not already been said in the questions then, and then the explanation as well, some brief explanation in the notes section of the slide, so you can look at it for future reference if you've missed what I've said today. So no need to panic. Okay, moving on. So this was a congenital heart defect question. See what people have put. This is a slightly harder question, probably, I'd say. Okay. So some of you went for A, some of you went for, a lot of you went for D. Okay, let's see what the correct answer was. So A was the correct answer. So this question tests a few things really. To answer the question, you need to know which of the defects will cause what we call duct-dependent circulation, where the majority of blood flow in a baby relies on the ductus arteriosus to stay open to maintain life. Okay. Because, for example, transposition of the great arteries, essentially the ventricles and the big vessels are mismatched, so that instead of left ventricles going to the rest of the body and right ventricles going to the lung, they're mixed up with, it's the wrong way around essentially. So, which is incompatible with life. But if the ductus arteriosus is still open, there's some mixing between oxygenated and deoxygenated blood, so that if they're still open, there can still be some oxygenated blood going from the left, from the lungs and then to the left ventricles and then to the rest of the body through the ductus arteriosus. And the other defects in the question also rely on a open ductus arteriosus. Okay, and by giving prostaglandin, or more precisely prostaglandin E1, is a vasodilator. So if you give it systemically, that's going to help and dilate the ductus arteriosus and keep it open. So then, before they have definitive treatments, say surgery and things like that, they can, they can have some perfusion to the tissues essentially. So therefore, which means A, patent ductus arteriosus, which describes the problem, is because the ductus arteriosus is still open. You wouldn't then give prostaglandin to keep it open, because that's the issue that you're having, if that makes sense. So in this case, the option A, patent ductus arteriosus, describes a situation where everything else is fine, but ductus arteriosus is not closing days or weeks after birth. So you wouldn't then give something to keep it open, because that would defeat, that would make it worse, essentially. In fact, in patent ductus arteriosus, you would give ibuprofen, which is a prostaglandin inhibitor. Well, COX inhibitor, I guess, but it inhibits production of prostaglandin to close the ductus arteriosus. Okay, so that's why that's the odd one out, essentially, which is, like I said, is the slightly harder question. Hopefully that makes sense somewhat. Any questions about this? No? Fantastic. Okay, let's move on. Question 7. Ibuprofen. Ibuprofen, as in the NSAID, is given to close pacing ductus arteriosus. Because if you remember, ibuprofen is, like I said, a COX inhibitor, and it inhibits synthesis of prostaglandin. Okay, so this is I need to give the answer just then. So most of you went for C. I'm just going to give it a couple more seconds. All right, so most of you went for C, IV sodium bicarbonate, which is correct. So in this case, this describes a scenario of DKA, diabetic ketoacidosis, and it's more like a rapidly worsening case of DKA, really. So, and it's important to know, for DKA, it's important to recognize it and know it, because I'd say it's probably more important to know how to recognize it, because in most trusts, when you're a doctor, there will be trust policies that you can follow quite nicely. Sometimes even the nurses will be quite, so like ED nurses will be quite well versed in how to treat it. But you know, relies on the doctor to recognize it in the first place. And the diagnostic criteria is in every part of the name. So you need, diabetic, so you need a high BM, you need ketosis, so either in urine or in serum, and then you need acidosis as shown on ABGs. Okay, you need all three to be present to say is a DKA, but a lot of the time, you know, from scenarios like this, we can have a good guess of the DKA and start treatment anyway. So going through the options, FRI is fixed rate insulin infusion, which is what you need basically to bring down the glucose in case of DKA. It's different from variable rate, which you would use in, say, hypoglycemia, or say if you're preparing someone for theatre. It's precisely 0.1 unit of rapid-acting insulin per kilo per hour. That's how much insulin you need for that particular person. 0.1 unit per kilo per hour, which is, like I said, there will be trust guidelines, and there's national guidelines on DKA that's very in detail. So there's no need to sort of force yourself to memorize it, I suppose. And then before that, you would do fluid resuscitation first. That is part of the guidelines. So you would treat it as if it's sepsis, for example, or just any shock. You'd fluid resuscitate first and raise the blood pressure to a ideal level, which is why I put the hypertensive part in the question. And then it's important, because you're giving insulin, and insulin can drive potassium into cells. It's important to monitor the potassium as you go, and replace any hyperkalemia that they might present with later on in the sort of continuous insulin infusion. So those three you need. And sodium bicarbonate is not really indicated, even though it might have some it might reverse the acidosis, but it doesn't have a role in DKA. It has a role in other cases of metabolic acidosis, but not DKA. Okay. Any questions about DKA or this particular question? Because DKA again is a massive topic. No? Okay, moving on. Okay. So, oh yes, this is the status question. Oh, we've got some disparity. We've got spread here this time, slightly. I'll wait for a few more responses to see more of a pattern. Okay. So most of you went for A, diazepam, but I say most, but it's quite even spread between the other options. So let's see what are the answers. So diazepam is the correct answer. It's kind of you know it or you don't kind of thing, really. So this is a very, again, classic description of a status epilepticus, where the boy, was it a boy? Yeah, is having sort of consecutive seizures without gaining without regaining consciousness in between. Either that, or you have a prolonged seizure in the same episode and prolonged seizure. And with sort of big medical emergencies like this, always a good idea to check a research council guideline. And so out of all four of these options, essentially that, well, like I said, it's just factually speaking, diazepam is not featuring, it does not feature on the research council guideline. Does anybody know why lorazepam is used? So lorazepam is one of the ones we would try first. Does anybody know why lorazepam is better than diazepam in emergencies? You can answer in chat if anybody has any idea. Yes, essentially. So that's a longer half-life is the better reason. So it's got a longer half-life in the CNS specifically than diazepam. So you can have obviously a more sustained effect. So very good. And also lorazepam has a slightly quicker onset of action. And those two combined, lorazepam is obviously preferred over diazepam in almost any kind of emergencies. But yeah, so that's that. Any questions about status? No? Okay. Yeah. So question 9. So another child with a cough. Okay, almost all of you went for D, oxygen. So let's have a look at the answer. And you're correct, it's oxygen. So diagnosis here is bronchiolitis, okay? And the pointers in the history, you've got respiratory distress, and you've got a wheeze, which means is a, it's a lower airway obstruction rather than upper airway obstruction, as we've seen before in croup. So this child is quite unwell. The obs are quite off, even for a 7-month-old. And most importantly, the SATs are quite low at 93%. So, in fact, for most cases of bronchiolitis, you don't really need to do much else than giving supportive treatment. So you would, if the SATs are low, you give the oxygen. If they become hemodynamically unstable, you give them fluid and things like that. But most people don't need anything else. In severe cases, if they're having, if their respiratory distress is not getting any better, and it's just deteriorating, then you might consider ventilation, which is still technically supportive treatment. But because anybody know what the most common causative organism is for bronchiolitis? Good, yeah, so it's RSV. So, which is why you wouldn't give Kermox, you wouldn't give, it's almost always RSV, so you wouldn't really give antibiotics, unless, of course, you suspect that it's not in fact bronchiolitis, but more likely to be a community-acquired pneumonia, maybe if they're showing signs of systemic infections and things like that. And they're not, and just giving them oxygen is not cutting it, that kind of thing. But yeah, so in this case, for, like I said, supportive treatment for bronchiolitis. Any questions about question 9? No, very good. Okay. Question 10, when you get in there, I know I do talk a lot. Okay. Yes. A good bit of abdominal X-ray. See who's the radiologist or surgeons among us. Okay, most of you went for D, intramural gas, and that is correct. So, this is, I've already, I forgot that I've given you the diagnosis already. So this is a classic case of neck, as the stem tells you. And again, this question is tricky because a lot of these signs you may see on X-ray with neck. So you might see dilated bowel loops, you might see obstruction, but there might be perforation, and therefore you might see air in the diaphragm. Again, regular sign is where, anybody know what a regular sign is? No. So regular sign is when there's presence of small bowel obstruction. Not quite. So I think, why is it D and not A? So D, so if we focus on D first, so intramural gas is pathognomonic for necrotizing enterocolitis because the whole pathophysiology, if you like, for neck is that the wall, that there's essentially bacteria in the walls of the colon in the baby, and which is why there is gas inside the walls, and you don't see that with any other causes of this kind of presentation. So if you see intramural gas on abdominal X-ray, that's straight away that is neck. Whereas all the other signs here can be seen in other pathologies. So which is why D is the most characteristic of neck. So that answers the second question. But regular sign, I think, if I'm not mistaken, if I remember correctly, is when there is air on both sides of the bowel wall, which again suggests perforation, a local perforation more likely. Does that answer your questions? Hopefully. So essentially, intramural gas is the most characteristic. It's pathognomonic for neck, whereas all the other ones you can see in other other pathologies, other causes of obstruction, for example, or perforation, things like that. Okay, but it doesn't mean to say you might still see them in neck, but you only see intramural gas in neck. Okay. So, yes, resuscitation. This is probably pediatrician's favorite question. I can't remember the amount of times I've been asked that as a student back in the day. Okay. So, neonatal resus for a baby who's just been born by C-section. What do we do? The baby is not looking great. What do we do first? So, most of you went for A, trying the baby, and that is correct. Very good. So, in any neonatal resus, in fact, especially when they're first delivered, you need to dry the baby and keep it warm. In this case, because it's an emergency kind of thing. Usually, I've actually seen this with my own eyes. Actually, this case is based on something I've seen. I was at the theatre doing the cesarean section, and this is pretty much the scenario that happened afterwards. But yeah, so when the pediatricians get called, they will have a station almost on a trolley that looks kind of like the old style scanners or presenters. So you put the baby on top, and essentially it's a radiator to keep the baby warm. It's been used in a lot of settings, but obviously it's very important in this kind of scenario. And the reason is that always comes first in neonatal resuscitation. And does anybody know why losing heat or hypothermia is such a big problem in babies in general? Any ideas? Any ideas why heat loss is? Yes, very good. So babies, because they're tiny, there's surface area to volume, or whichever way around you want. It's a lot larger than it is for adult humans. So which means that they have a lot more surface area per volume to lose heat from. So which means they lose it quite quick when they decide to start losing heat. So which is why it's always important to keep them nice and warm, nice and dry, nice and warm. So very good. In this case, I've kind of skipped a step, but in the sort of less traumatic deliveries, or in any delivery really, anybody know what score you can use to evaluate how well the baby is doing straight after delivery? Good. Yeah, I've got a score. Which again, if you did the score, this baby is not doing very well at all. But yeah, the point of the question is, again, you would do all those things. You probably, because the baby is not crying, you probably would do airway maneuvers eventually. And I think in babies, you would, if I'm not mistaken, I think you do jaw thrust quite, there's a low threshold for doing jaw thrust, but anyway, chest compressions and inflation breath, these are still things that you would do as per, normal resus, if you like, normal adult resus. But the methods are obviously different. So for example, the chest compressions, you're doing it with 2 thumbs at most, or just 1 finger even sometimes, that kind of thing. But yeah, so this is the thing to keep in mind when you're resuscitating a neonate. Okay. So moving on, we're nearly there. Okay. Okay, again, this is a question that's put them very much on purpose to contrast a previous question, as you can probably tell. Good. Okay, most of you went for, we'll just hurry things along. So most of you went for B, throat swab, and that's correct. Anybody know what the diagnosis is? Quickly. Kawasaki, very good, yes. So I put this question here on purpose because we just had a look at scarlet fever early in the presentation, which some of the features are very similar. So it's a very classic differential between Kawasaki's and scarlet fever. Things like the rash, the strawberry tongue, the fever, it's sometimes can be quite hard to differentiate the two. But in Kawasaki's, these things appear in order. So if you look at Kawasaki's diagnostic criteria, there's 7 things on there, which I've got most of them. Can't remember which one I've missed out now. But these things, they happen in sequentially. Whereas, in scarlet fever, they can just happen all at the same time. And then more importantly, there's the sore, you can expect a sore throat beforehand. But obviously that doesn't mean you can't have a sore throat before Kawasaki's either. So, but yes, well done for picking up Kawasaki's. Throat swab is contributes the least because the clinical presentation is quite clear, quite convincing of Kawasaki's. So doing a throat swab to exclude scarlet fever is probably not going to add as much as the others. And the reason is because immunoglobulin is the first line treatment in Kawasaki's. Anybody know why aspirin and echo is relevant? Aspirin first. Anybody know why aspirin is relevant? No. So in Kawasaki's, there's a risk of MI or just any thrombotic event because it is a systemic vasculitis, Kawasaki's. So there's a thrombotic risk in children who have Kawasaki's. And to prevent that, as you would prevent MI risk in an adult, you would give aspirin. That is a very rare occasion where you would give aspirin to children. I didn't know this before until quite late, but aspirin in most circumstances, almost all circumstances apart from the Kawasaki's, is contraindicated in children. Okay, so that's something to bear in mind when you're prescribing. An echo is relevant because, again, in Kawasaki's, you can get coronary aneurysm as a result, as a complication of Kawasaki's. So you want to sort of screen for that. You probably want to do that. You want to do repeat echoes as well as the child grow older. Hence why the echo is relevant. So all those things are included in the management plan, should be included in the management plan for Kawasaki's once the diagnosis is established. But so therefore throat swab is going to add delete. Any questions about question 12? No? Okay. So I've got a nasty, very evil rash. So let's see what you guys put. Again, this is the kind of question you either know it or you don't. Most of you went for B, Castraxone. That's correct. So this is a case of meningococcal septicemia. Very dangerous in children. The non-blanching rash is very scary, and when you do see it, do panic in children. But it's worth noting the difference between meningitis, even if it's meningococcal or not, and meningococcal septicemia. So you can have meningococcal meningitis without having the septicemia part. Equally, you can have full-blown meningococcal septicemia, but not really much signs with meningitis, because meningitis suggests local inflammation of the meninges, which may or may not be present with any case of meningitis infection. Not meningitis infection, sorry. To be precise, a case of meningitis infection, because it might not be local. It can't just be systemic. Anyway, so option A, benzodiazepine, is the option for community. So if you're in GP or whatever, then that will be the antibiotic of choice if you're suspecting meningitis. Whereas KEF is what you would use, either Castraxone, sometimes some hospitals use Cefotaxime, is empirical antibiotics of choice in hospital setting. Cepro is what you'd use to give close contact for prophylactic use, and gentamicin is just not used. That's it really. It'll be quite unless you've grown something that's sensitive to gentamicin, of course, which in this case we don't have that information. Any questions about question 12 or 13 even? If it was meningitis, would it still be Castraxone? Yes, that answer is yes. So the antibiotics choice is still the same, but I just brought that up because the presentation will be different. You might see more neuroscience with meningitis, actual local meningitis, and but yeah, in terms of antibiotics, it's the same. Unless you've grown something else, because obviously not all cases of meningitis, despite the name, are caused by N meningitis. So, but you will still start with KEF empirically and then change it afterwards, even if that's the case. Okay. Just 2 more questions now. So this is just a fact recall. Okay, most of you went for B, polycythemia. So it's the congenital hypothyroidism. Again, like I said, it's just, you know, it's either you know it or you don't. The preterm birth, maternal diabetes, obviously, because of the insulin levels in diabetes in a mum, you can almost expect neonatal hypoglycemia. And preterm birth is at risk of pretty much everything. And when they're born, polycythemia, I think is because must be because when in the child, when there's polycythemia, I think it affects the osmolality, I want to say, of the plasma, and therefore you have less constituents of things. But don't quote me on that. I don't know off by heart the exact reason for polycythemia causing hypoglycemia, to be honest. But congenital hypothyroidism doesn't cause hypoglycemia. Okay. And then moving on to the last question. Okay. Yeah, so most of you went for target sign, and that's correct. So, what's the diagnosis, everyone? Anyone? Good, yeah, intussusception. The giveaway is probably the red jelly-like, or some people say red currant-like jelly-like stool. The sausage-shaped mass is quite characteristic as well. No, I can't spell it either. I can never spell it. Double beak signs. I'm going to go through each sign where it's seen. So coffee bean sign is a sign of volvulus. Just any volvulus you can see that on abdominal X-ray. Usually seen either in the ileocecal area. I think the other site is, I want to say, sigmoid. So the two bottom corners, basically, the left and right bottom corner, which is not very scientific. Whirl sign is, you see that in malrotation, or even malrotation of either the bowel loops, and then the whirl sign is because of the SMA being twisted, essentially. Or sometimes you can see the word whirl sign being used to describe testicular torsion on ultrasound as well. Both of those on ultrasound, really, but one's abdominal, one's scrotal. Double beak sign is a sign seen on CT, and that's a sign of closed loop obstruction. By closed loop, I mean there's two obstruction at the beginning and the end of the segment of bowel loop. So because you can have obstruction just at one point, and that's still obstruction, but it's more dangerous to have 2 points of obstruction, and therefore double beak sign, what we call double beak sign, because that massively increases the pressure within that section of the bowel loop, and therefore predisposes itself to perforation. Okay, I think that's pretty self-explanatory, that last question. Okay, so that's all of them. Sorry I go on for a while. I think we just hit that hour and a half mark. Any questions about anything we've gone through today at all that I can answer quickly? Okay, so there's the QR code for feedback. I'm happy for Thursday 15 to share out my email address if there's any questions about this or just about anything in general. I'm happy to reply to you guys, but for now I'll hand it back to I'll hand it back to Alex, I think. Oh,
Yeah, nice one. Thanks everyone for joining us today. And I've put the link in the chat as well. If you're on your phone, you can't scan the QR code. So please fill it in and we'll send you the slides along as well.
So I've got a couple of questions on here. I just saw them, sorry about that. So I'll go for the Coombs test question first. So why would you do Coombs and not the other options for question 3? So it's not that you don't do the other ones. Like I said, I don't know if you I don't know if you were there, but the other options like FBCs and bilirubin, you definitely still would do, but because the question stem strongly suggests there might be previously undetected rhesus disease as a major differential, that's why you need to do a Coombs test as the first instance to rule out rhesus first, because if it is rhesus, then you want to give anti-D as soon as possible, essentially, or even more drastic measures, which is why you want to do direct Coombs test preferentially over the other more routine things like FBC and bilirubin levels and things like that. I can't remember what the other option was. So in reality, you would do all of them, but the most important test to do is direct Coombs. Okay. And what's the sign for molar pregnancy? So molar pregnancy can be easily picked up by a very abnormally rising or high or rising beta HCG. On ultrasound, it's not, I don't think it's grapefruit sign, not whale sign, I think, on molar pregnancy, because essentially what you have in molar pregnancy is that you get, I don't want to call them cysts, but it looks like they pretty much are cysts, where the uterus is first of all massive, and within it you get little pockets of growth, essentially. On ultrasound, instead of having empty uterus and then you get the fetus, you get a massive growth, I guess, mass on ultrasound, and then you can see little holes in it, and it looks like grapefruit, I think. So that's where, as opposed to a whorl, which suggests things are twisting, which doesn't happen in molar pregnancy. Is that all right for answers? Any other questions? No? Okay. I'll go back to you then, Alex. So yeah, hopefully, for people who are still here, I've tried to cover as many different areas as possible, but there's a lot to look into in peds, and hopefully that's been a good pointer to what needs to be looked at in peds. But yeah, thank you for coming.
Yeah, great session. I feel like I also learned a lot. So thank you so much. I will end the session now.
Okay.
Hope everyone has a good evening, and we'll see you guys next week.
Yeah, have a good evening, guys.
Yeah, bye.